In our study, we had a small sort of population study we conducted in 10 villages that we were serving and about to serve. And we asked people, was there a time when you could not go to the health, when you did not go to the health facility, but you wanted to? And then we asked those people who said yes, why? And 74% said the cost of transportation was a major barrier for them going. So yes, it's distance, but it's also, the cost, because here somebody has to jump on a boda and, pay 10, 15, 20,000 shillings, which is just way too much. Why does this matter? To fight HIV, patients have to stay on anti-retroviral treatment. That prevents new infections, that prevents mutations and resistant strains from popping up. And, on a personal level, it allows somebody to live a long, full life. That's the same true for infant and child mortality. Mothers and babies have to visit the health facilities. If you want to improve infant and maternal mortality, to reduce infant maternal mortality, you have to have antenatal care visits. Here the prescription is at least four antenatal care visits, delivery at a facility, postnatal care visits, including immunizations. And so if you live far and you're not accessing those services, you're going to have worse health outcomes. In the context that we work in fishing communities in Kalangala, Rakai, and Masaka. And another story of the 21st century in the HIV epidemic is the key populations, right? Areas where the incidence, the prevalence rate of HIV is much higher than it is for the average population. So the average right now is getting close to 6% in all of Uganda, but in some of these fishing communities, in some of these districts, it can be 15 to 30% in particular villages. So the story of our time is, okay, we need to target these communities, which are men who have sex with men, sex workers, truckers, and fishing communities in Uganda. And so many are remote, and so getting access to services is critical. So distance is bad for your health. And the model of waiting at the health facility for patients to access services is totally broken. It's anachronistic and it's not working. So we need to bring services closer to people. And so Health Access Connect, and my next role is to convince you that Health Access Connect is unnecessary to address this major global problem. So our mission is to link Ugandans living in remote areas to healthcare resources. You would classify us as more of a last mile intervention or a health logistics intervention. And also when you talk about HIV, they're called differentiated service delivery models, or differentiated care, of which is talked about in most presentations I've been to here. And what is important, I think, is that in doing this, you must work within the Ugandan health system and strengthen the ability of the Ugandan health system to solve these challenges. So that's where we're coming from. And our major and so, like I said, we're working in these fishing communities. And the problem that we really started with, was the sort of puzzle that we're dealing with, is that people are still dying of HIV/AIDS in these communities, yet free life-saving healthcare is 5 kilometers away. It's just right there, and it's totally free. It is more expensive in other countries to access this care than it is in Uganda, and yet there's still a major problem. And so our solution is this program called Medicycles, which we conduct monthly or bi-monthly one-day integrated care outreach clinics in remote areas. So every month, or every 1 or 2 months, depending on where you are, that your health workers are going to come and give integrated services. So I want to break down what is necessary, the model for what is necessary to conduct an outreach clinic in Uganda. One, you need 2 to 4 health workers. You need medicine and supplies. You need a means of transportation like the one pictured here. You need someone to mobilize patients to get them to turn up in these remote areas. And then you need the money to cover these costs. And so I want to break down these 5 components so you understand what sort of goes into each one of the outreaches we work on. 2 to 4 health workers. Why 2 to 4? We try to really push for 3. One person to conduct HIV testing and anti-retroviral treatment, a second to work, usually a midwife or nurse, to distribute family planning, maternal child health, which are in high demand in the communities that we serve in these remote communities. And then someone for general treatment, and that includes treating sexually transmitted infections. There's a lot of malaria treatment and fevers, diarrheal diseases, and basic child checkups. And then you need medicine and supplies. And in the Ugandan health system, just like the health workers, these things are available for free in Uganda at public health facilities. Yes, there are issues. Yes, there are stockouts. But Ugandans can go to their nearby health facility or one a little further away and access free medicine and supplies and health services through government health facilities. And that's what we're trying to bring down to the ground. A means of transportation to get to the area is a boda, which is a motorcycle taxi. Many health facilities have their own vehicle. Maybe a health worker has a motorcycle, or they have a car that was there for whatever reason, and or a boat in some of the island communities. So you need a means, a reliable means of transportation. For us, we now work with over 12 health facilities. If we go to a health facility and they don't have access to a reliable form of transportation, maybe the boda guys who are nearby are not reliable, can't show up on time, you can't really trust if they'll sort of go off, then we use microfinance to give a loan to a guy to run his boda business, and he has to be there to serve 3 villages for that health facility. So that means 27 days out of the month, he just runs his normal business, but then as a condition of his loan contract, he has to be available for that whole day, for that outreach clinic day, for the health workers to go pick up records or make 2 trips on his boda to take the health workers and their supplies down. And then lastly, you need somebody to mobilize patients once you get there. You can't just show up, have a clinic and expect people to come. And so, this woman here is a VHT who is using a megaphone. And so she will go around and the night before and the day of and say, hey, you guys need to come out. These are the services that are going to be provided. These are the services that will not be available, which is a big issue that we are working with, and get people to turn out. And lastly, you need money to cover the costs of the outreach. This is really where the rubber meets the road. You need at least 17,000 shillings for each health worker, musawo, and that is just under $5. You need 20 to 30,000 shillings to pay for the fuel in this case, and that is $5 to $8. And then you need 5,000 to 10,000 shillings for the community health worker, the VHT, who has gone around and mobilized everyone, who sits outside of the outreach clinic collecting for people, signing people in. It adds up to around $22 to $28 for a one-day outreach. That is the bargain of a lifetime. You can spend $22 to $28 and you can reach services to that last mile, the most difficult to reach communities in Uganda. Why are we unnecessary? Because the community can provide for these costs. Each patient, in our model, each patient pays 2,000 shillings, half for children. And if each patient is paying 2,000 shillings, which is around 55 US cents, you can pool that, and if you have at least 40 patients attending somewhere in there, they'll cover the full overhead costs, those travel allowances for the health workers, the fuel or transportation for the motorcycle, and a really small allowance for the community health worker. So we are not putting any resources into actually covering the overhead costs for these outreaches. And I want to talk about our achievements doing this. Currently, we serve over 30 villages with monthly or bi-monthly outreach clinics, and this is true through February of this year, and our first outreaches were in August of 2015. We reached over 10,000 documented patients, and the average patients per outreach are somewhere around 44. And close to 4,000 people have given ART, and a large percentage of children and adolescents. The numbers that we're really proud of are the number of males that attend. I think service providers, many of whom are here, have really struggled. How do you have a health intervention in which males are actively involved? And males are turning up to the way that we are working. And note again, each of these outreaches, patients have had to pay 2,000 shillings for an adult patient and 1,000 shillings for a child to turn up and get these services. And these are our sort of annual service numbers. And I'll point you to, and so last year, 2018, we had a big sort of scale up for us. We were sort of going a bit, trying to sort of refine our model in those first few years. And then in 2018, we reached 30 villages with these monthly outreaches. And the last column is the one I want to draw your attention to. This is dirt cheap to reach these really hard to reach areas, because we're covering, a lot of the way we spend money is, hire field staff who does community organizing, who sets up, who makes sure you have continuity of care in these areas. We pay a lot of money for transportation to get those people out to villages, to organize communities, to meet with health workers, and just basically go around and set up this sustainable system in which it's a direct relationship between the communities and their health workers. And so over and over again, we do a lot of community organizing and health logistics, addressing problems that arise like medicine stockouts, people showing up late, some issues with the quality of care that's delivered. And so that's our role, is to sort of make sure that this system happens, and month to month, you're giving services. We work in the districts of Masaka, Rakai, and Kalangala. We're currently expanded to Chotera and Kalungu, if you guys know those areas. We really started in Kalangala in that series of islands in Lake Victoria, which is why HIV services, ART, and HIV testing were sort of at the center of our model in the beginning, but sort of expanded on that to have a more integrated model. And now this is not a totally complete map, but we're sort of continuing to move along the Lake Victoria region because of the difficulty of reaching these populations and these villages and sort of the needs of these key populations. And so our vision for what to do next is to build a network of these remote villages. Think of all the people here who have spoken on the amazing services that they provide. Well, if you were able to come to Health Access Connect and say, hey, we have this thing we want to deploy. We want to roll out a new yellow fever vaccine, and we want it to reach the most remote areas. Well, we're going, our partners are going to these remote areas every 1 to 2 months, so you could easily roll out a range of services. And also communities have been requesting other services. They say, well, can we have a dentist come out? Can we have an ophthalmologist come out and do some eye checks for people? And they can reach out to the districts and say, oh, well, every 6 months a dentist can come out. And you know what a dentist does in rural areas of Uganda is to pull teeth. And that's what, honestly, that's what it is. And so, you need a dentist to come out every 6 months and pull a bunch of teeth. Well, now you've got the system in place to actually go and do that. And the same with an ophthalmologist. I've been with friends in these remote areas, and they don't ever get their eyes checked, that they obviously have some vision issues. Well, if you brought someone there and say, hey, come for an eye check, 2,000 shillings, it's a deal, and that ophthalmologist often sits idle in the sort of district hospital or health facility. We can use those strategic partnerships to continue to expand and improve services. If you're having a rollout of digital tools that you're going to use, or you want to try out new treatments or research projects in these remote areas, then we can connect with those. We also know because we sort of interact with the local populations a lot, we know what services they are demanding. For instance, water and sanitation. People want toilets and they want wells, and they don't have them. So we can bring that information to other service providers who are comfortable in sitting in some of the main cities and are sort of need projects and sort of work on some things together. We want to have global impact. I think this model is appropriate to many sort of resource-limited settings where you have services, you have health workers and supplies, and they just need to sort of reach that last mile, and there is a way to do it. And so when I say that Health Access Connect is unnecessary, unnecessary equals sustainable. You need low-cost models in which you can really improve the Ugandan health system, not have some sort of parallel system that you're building to provide these services. And that's it. Thank you.